I'll take this opportunity to introduce the moderator of the session, Dr. Nachiket Shankar. Yeah, Nachiket, I know him for last few years because he came and conducted one very nice workshop along with us in one of the medical education conferences. He heads the Department of Anatomy in St. John's Medical College. He's got a keen interest in medical education and research methodology. And we would say that more than that, he's got a very keen interest in making things very clear. He actually puts it across in such a nice way that it becomes very explicit for the listeners. So that is one. He is very active in the Research Society and also in the Department of Medical Education. He enjoys teaching music and sports. He has given us a very little to go by, but I think after listening to him today, we would know much more about what he is and how to go about. And I would request Dr. Nachiket to introduce the rest of the panelists. And before I hand over to you, there is a few housekeeping announcements. I request all the participants to keep themselves on mute mode so that the audio quality is good for everybody. And for the benefit of everyone, I would like to say that this session is being recorded for academic purposes and posterior use. Over to you, Dr. Nachiket. Please take over.
Thank you so much, Madam, for that kind introduction. And good afternoon to one and all. At the outset, the team from St. John's would like to thank the organizers for inviting us to conduct this panel discussion on clinical reasoning. And let me begin by introducing the panelists from St. John's Medical College, Bangalore. I'm going to share a slide each about each of them. So the first panelist that I'm going to introduce is Dr. Sanjiv Lewin. He is the Chief of Medical Services and a Professor of Pediatrics, Clinical Ethics and Medical Education from St. John's Medical College Hospital, Bangalore. And he's also the visiting clinical professor at the University of Maryland at Baltimore. And his areas of interest include ambulatory teaching, clinical reasoning, critical thinking, disaster medicine, pediatric HIV medicine, professionalism, and ethics. He has a vast experience in medical and pediatric education, and he was the ex-head of the Department of Medical Education and ex-convener of the Nodal Center, the ex-head of the Department of Ethics, Disaster Relief and Training Unit, and he is also a clinical mentor and instructor of pediatric HIV, AIDS Relief Africa and South America. He is the ex-member of MCI's undergraduate academic committee for ADCOM, Basic Advanced Faculty Development Courses. He has 5 publications to his credit, and he has received a number of teaching awards, including the Pioneer Award for Best Teacher and the AICHEE National Teacher Award. So we have with us Dr. Sanjiv. That's Dr. Sanjiv for you. The next panelist is Dr. John Stephen. He is a professor of dermatology and he is the head of Department of the Medical Education. He has over 20 years of clinical and teaching experience and 12 years of medical education leadership. And he is at present the convener of the MCI Nodal Center for Faculty Development. He was the former member of the WHO Guideline Development Group on common skin and oral opportunistic infections in children and adults. So that is Dr. John Stephen. And the third panelist that we have is Dr. Suneetha. She is professor and head of the Department of Ophthalmology and a member of the Department of Medical Education. She has completed all her training from St. John's Medical College, and her areas of interest in medical education include assessment, clinical reasoning, and research in medical education. So, as mentioned previously, the focus of the panel discussion will be on clinical reasoning, and the panelists will answer some important questions related to clinical reasoning for around half an hour to 40 minutes, following which we will have an open house for the participants to interact with the panelists. And if you do have any questions, please type them out in the chat box, and we will address these questions during the open house after all the panelists have answered the questions that have been put to them. So we will begin the panel discussion. by asking two very important questions. The first question is, what is clinical reasoning? And the second question is, why is clinical reasoning important? And these two questions I address to Dr. John, and I request him to please answer these two questions. And I'm going to just ensure that he is able to share any slides that he wishes to. So I'm just going to make Sir the presenter. Over to you, Dr. John.
Thank you, Nachiket. And let me answer those questions, the two questions. What is clinical reasoning and why it is important? I want to share my PowerPoint with you, and then can you see my PowerPoint?
We can see your PowerPoint, sir. Yes.
Sure. Yeah. This is St. John's for those who've not been in St. John's, and the campus as a whole. And so the question is, what is clinical reasoning? Very briefly, if you want to say what clinical reasoning is, basically clinical reasoning describes the thinking and decision-making processes associated with clinical practice. So generally, as doctors, when we come across a patient, the patient comes to you with a problem, and what do? We hear the problem, we take a history, we gather information in history, we gather information on clinical examination, we may have additional information from investigations. We gather that data, and then we compare it with our knowledge that we have in our brain, in our head, in our brain, and knowledge that we've read from books, knowledge that we have from seeing other patients. So by comparing and contrasting, and we reason out the diagnosis and a treatment plan. So essentially, this is what happens in our interaction with patients. So if you look at the clinical reasoning process, that's the heart of this decision-making with diagnosis and treatment, basically has 4 steps. The first is, of course, we acquire data, and then we either interpret and organize or organize and interpret. Then we generate a differential diagnosis, and then we sort of test the hypothesis on whether the diagnosis that we've chosen fits in or is it appropriate. In some ways, it's sort of similar to what happens with the learning process itself. I think we are familiar with this as people from the medical education background, the Cope cycle of learning. In some ways, when we come across a patient, we come across the problem that the patient presents with. We observe the clinical signs. We gather information. And with the information that we've gathered from history, clinical examination, investigations, we begin to, this happens inside the head. We think about what are the possibilities. We compare with the information that we already have. We reflect on the information that we have. And then we make some assumptions, some hypotheses. Then we maybe confirm it by doing some tests, and it goes on. In a way, there are 2 parts to what happens, whether it is in learning or in clinical reasoning. We gather information that's from the outside. And a lot of thinking and comparing and contrasting happens within our heads with what information we have that we've gathered in the past, in book reading and otherwise. And then we test out that particular hypothesis. So the gathering part of it is what occurs on the outside, but the thinking part of it and decision-making occurs on the inside. So in a way, the reasoning occurs inside the head, actually. And in our situation as doctors, we are sort of relating it to clinical reasoning in dealing with patient problems and how we solve patient problems. Now, actually, we can go back to understanding what actually happens in learning in the brain. And, we get information from the outside. Even if we were to look at this as reasoning for any other reason other than clinical reasoning, we get information from our sight, from our hearing, from our touch, from all the senses, and the information gets in. And then there is this very important structure, that is the hippocampus. It is at the hippocampus that these information that's coming in gets processed in a way, and that gets stored in the prefrontal cortex. And when we come across a situation again, this information that is stored in the prefrontal cortex is again sort of retrieved and compared, and that's what happens. So the most important structure here actually is the hippocampus. I want to, with a simple example, it could be like this. When we gather information, when information comes into the brain, it just comes at random, and you get so much of information. It's the hippocampus and the processing that actually sort of filters it and looks at what's important and then stores it in the cortex. And when it stores in the cortex, it stores the information in an orderly manner. So you could pick up a book and say, okay, this is not important, and throw it away, not store it, or find it important and store it adjacent to the previous volume. So this is what the hippocampus does. So if you were to look at, let's say, for example, chest pain. So a patient comes with chest pain. The hippocampus will take all the data that we gather from history, from investigations, from examination findings. And if you look at it, what it does, it has stored these information. When we read information, we see patients, it stores this information in a particular pattern. And the pattern, I've given two examples, there have been many examples. It could store the information in an anatomical sort of a structural pattern, or based on pathophysiology. Yeah, based on pathophysiology, it would store it in, let's say, inflammatory conditions, aortic dissection, thromboembolism, or it could go into a different structure based on anatomy. It could store whether it's unilateral, whether it is central. And so there's different ways in which it could be structured. So information coming in gets stored in the brain in a particular pattern. So this brings us to another term that we use called scripts. Scripts are organized mental summary or construct that we use to create memory. When you're talking about clinical reasoning, you're talking about illness scripts. I suppose we have scripts for other things as well, but for clinical reasoning, we call it illness scripts. In illness scripts, they are basically an organized mental summary, a construct that clinicians use to create clinical memory. They are based on our own experiential knowledge about diseases and conditions. So there are many ways in which we structure this script. It could be based on pathophysiology, epidemiology, time course, symptoms and signs, diagnostics, treatment, and in so many other patterns. And it's sort of interconnected in a way. So what happens how do we use these scripts? For example, let's say a patient comes and presents to us with headache. You take a history, you examine clinically, you look at some investigations, you compare the patient script with the script that you have in your brain. And your script that you have in your brain could be based on a structure like that. Let's take headache. And if you, let's say, for example, I've given you a script for migraine. It may be stored in this way. The pathophysiology, what causes the disease? Disease is unknown, but believed to be due to genetic factors. So is genetic factor, is there a family history, something that you may want to ask in history? Epidemiology, who gets the disease commonly? More in females versus male. And it goes on like that. A unilateral throbbing headache with nausea and vomiting and photophobia. So this is a script for migraine. So this is how we've stored information in our brain based on reading, based on seeing patients. So when we look at patients who come to us, we don't sort of compare and contrast based on a single script. We often compare and contrast based on a differential diagnosis. We have more than one hypothesis here. Patient comes with a headache. We will perhaps have more than one script that you want to compare. I've given examples here. One script is for migraine. One script is about meningitis. Another script is about a cranial bleed. So when you deal with patients who come with a problem, you are comparing the patient's script, not just with a single migraine script, but with a differential diagnosis, that is multiple scripts. So when you have multiple scripts that you need to compare, actually what happens in the brain is your information is stored in something called script tables. Basically, for headache, you have a script table which has more than one differential diagnosis. So you could have something like this for headache. And when you compare, let's say, for example, you can take and say the patient is gender, whether it's a female or a male. Yes, we know some information, but that information is not really helping me distinguish between migraine, meningitis, and intracranial bleed. So it's not a differentiating factor. Let's take vomiting, for example. It's present in all these conditions. Perhaps vomiting is the one that brings all these scripts together into the table. If you look at fever, fever is sort of unique to meningitis. It's a differentiating factor. It's sort of a key factor. So some of those features will be key features. Some of those features will be non-differentiating features. Some of them will be differentiating features. For example, stiff neck. Stiff neck may not be present in migraine, but it's certainly there in meningitis, but may also be there in intracranial bleed. What about investigations? So if, let's say, if you get a spinal fluid testing you do and the CSF analysis says it's absolutely normal, maybe that's another differentiating factor. In a way, it's a rejecting factor. Basically, it rejects the diagnosis of meningitis. So this is one way to compare and contrast. You can do this more diagrammatically with a Venn diagram as well. If you look at vomiting, it's present in all the conditions, so it's a non-differentiating factor. If you look at the neck rigidity, we've written for intracranial bleed and meningitis, it's a differentiating factor. It sort of takes away migraine. If you look at fever as a key feature, if you choose to do a CSF analysis, I put it outside here, but once you get the report, it could fall either into meningitis when you have a diagnosis that the CSF analysis, that will be again a sort of a key feature, or if it is normal, it becomes a rejecting feature. So when you look at it, we acquire data, we organize them, we interpret and organize them. We have a differential diagnosis. We use the script of the patient and compare with the script that already exists in our head, in our brains. And we have these hypotheses that we use and compare. And once you compare, we come to some sort of a certainty about the diagnosis. For example, we may say migraine is sort of 60% certain. Intracranial bleed is uncertain. I'm not very certain. On the other hand, meningitis with a normal CSF, it's very unlikely or likely. So we sort of come to different grades of certainty here. And if you look at it, based on the certainty, there are certain decisions that we make. If there's enough data to confirm the diagnosis, we go ahead and treat. Let's say the CSF is normal and the features fit in with migraine, we say, okay, let me treat it. But if you still have doubts and say, I'm not sure this headache, is there some intracranial bleed? It's an elderly person, he's a hypertensive, so I'm not very sure. So it becomes an uncertain. So you want to do some more tests to confirm it. But if you have data, enough data there to refute the diagnosis, you trash it. So what we do in every situation is actually we draw these two lines. One is called the treatment threshold. The other one is called the testing threshold. Now we fix these two thresholds for different situations. I'll give you another example. Let us say a patient comes with sudden onset dyspnea. If your pulmonary embolism is one of your differential diagnosis, you will move the testing threshold down. If you're 30% sure of, if there's a 30% chance of pulmonary edema, you're not going to thrash it. You want to actually make sure you rule it out. So your threshold will shift to further investigations, right? Because it's a condition that could be fatal. So you want to be absolutely certain before you thrash it. So based on this, you make the decision on whether you want to further test it, or you want to thrash it, or you want to treat it. If you're in the uncertain area, what do? You test it. So we take a history physical, we acquire data, interpret and organize, generate a differential diagnosis. You came to some hypothesis there and you're not very certain. So you do further investigations and go back, take the information and come back to refining your hypothesis. And you sometimes will be called upon to go back and take history as well, or go back and do further investigations. So by this process and this cycle, we begin to sort of refine our diagnosis. And that's how reasoning is actually done. So if you look at it, patient comes with a problem, you have gathered information, you compare patient illness scripts with existing illness scripts. And as you see more and more patients, you're refining your illness scripts. You're adding more illness scripts and more differential diagnosis. So with every patient you see, this illness scripts that are there in your head actually increases in a way. So it's not only the illness script, it's sort of stored. The differential diagnosis for each of these conditions begin to increase as well. So what happens is that, for example, in the headache, we had these 3 differential diagnoses. Maybe as you see more and more cases, you start developing a network of illness scripts. And this is what happens. And if you look at this diagram, I would say the first one is like what happens to an MBBS graduate. The second may be a postgraduate. And the third may be a senior experienced clinician. At the end of the day, it's about the networks of these illness scripts that you develop. And the more the network, the stronger the network, I guess you'll be the better the physician you'll be, the better clinician you'll be. And so that brings us to the second question that Nachiket asked. Why is clinical reasoning important? I think it's quite obvious. If you look at it, at the essence of being a doctor is the patient comes to you with a problem. You will gather information about the problem. You'll use your illness scripts and do a clinical reasoning to come to a diagnosis and treatment. This is the essence of being a clinician, a physician. And building these networks of script tables and clinical reasoning is the essence of being a doctor. Now, I want to end with this one particular picture here. Essentially, we have 3 things that I put together: information gathering, clinical reasoning and processing, and come to a diagnosis and management plan. The strength of any chain is dependent on the weakest link. If you look at our teaching that we do, most of the time we spend a lot of time on information gathering, history taking, clinical examination, and other things. We do talk about treatment and other things. I think the weak link is actually this clinical reasoning, and it's absolutely essential if you want to be a good clinician. So I hope this answers the question, what is clinical reasoning and why it is important.
So thank you so much, sir, for simplifying such a complex topic and giving the importance of illness scripts in clinical reasoning. And it's the richness of illness scripts that determines how good the clinical reasoning process is. And you also beautifully explained the neurophysiological basis of clinical reasoning and also addressed why it is important. So thank you, sir. So now we want to go in depth into the topic. And for that, we will try and sort of go and see what the steps are in the clinical reasoning process. So for that, I would like to request Dr. Suneetha to answer the question as to what are the steps that are involved in clinical reasoning. So over to you, Dr. Suneetha. I'm going to make you the presenter. So you should be able to share any slides that you want to now. And as we are waiting, I request the participants to please type into the chat box any questions that you might have. So we will address those questions once all the panelists have answered the questions that I have asked them. Thank you. Ma'am, I think you have to unmute it, ma'am. I think you're muted. Yes.
Okay. Now, okay.
Yes, ma'am. We can hear you clearly, ma'am. Yes, ma'am. Thank you.
Okay.
Ma'am, there's some issue with audio. We're not able to hear you clearly, ma'am. Yes. No, still, ma'am, still some
I
disturbances
think
there.
there is some looping going on between the two people who have joined. Both of them have joined from same area. I think there is some looping going on.
The other company to
Okay, fine. Ma'am.
Nachi, can you allow me to share?
Yeah, please, sir. I'll do that. Just give me a minute, please, sir.
Okay.
Yes, sir. Yes, sir. I have given you permission to share, sir. Please, sir. So, as Pam is sharing her slides, this question is related to the steps. What are the steps that are involved in clinical reasoning?
I'll use this. Okay, so sorry about that. So I'm going to use a case scenario to explain the steps in clinical reasoning. So if you imagine yourself in the emergency department and the attendant, the triage nurse comes to you and says there's an elderly male who's presenting with shortness of breath and cough. When do you think clinical reasoning will start? It starts right away, isn't it? Even as you're informed about the shortness of breath and cough, we start thinking of potential differential diagnosis. What could it be? Could it be acute on chronic bronchitis? Is it community-acquired pneumonia? Is it congestive heart failure? Or could it even be pulmonary embolism, elderly male? So then we start seeing the patient, apply clinical reasoning, then which will help us to come to the most probable diagnosis and then start treatment. So what are the phases in clinical reasoning? It includes data gathering, organizing the data obtained, generate differential diagnosis, choose appropriate diagnostic tests. Based on that, narrow down the DD or maybe even change the diagnosis, plan and institute treatment. For the purpose of this next 10 minutes, I'm going to only focus on these two, what has been highlighted, how to organize the data and generate differential diagnosis. Because as Dr. John said, we do spend a lot of time teaching our students how to gather data appropriately, and most of the times we do very well. We also teach them how to plan and institute treatment. So very briefly, continuing with the same patient, many of you all are familiar with this diagnostic funnel. Studies have shown that almost 85% of diagnoses are established on a good history and physical examination. We often use diagnostic tests maybe to confirm our clinical impression, less often to maybe change the diagnosis completely. Keeping that in mind, we take a detailed we gather history. So continuing with the same patient who is presenting to us in the emergency medicine with shortness of breath and cough for 2 days duration, which has progressively worsened. There's an history of associated fever and occasional blood-thin sputum, and there's also sharp pain in the chest on coughing. He's a known smoker for the past several years. He's a known diabetic and hypertensive on regular treatment. The DD has not changed much with even this much of history. Whatever we thought of in the beginning. Keeping these 4 differential diagnoses, we'd like to rule out some negative history, and this is what we have obtained. There's no past history of respiratory problems, no past history of cardiac illness. There's no history of pain, swelling, recent periods of immobility, pain and swelling in the legs, and periods of immobility. History is complete. We do a detailed physical examination, and these are his vitals. There's absent JVP, pedal edema is absent, patient is visibly breathless. Respiratory system examination reveals bronchial breath sounds with crackles in the right lower chest areas. There's dullness on percussion, and there is symmetrical chest excursion. Other systems are essentially normal. So a lot of data has been gathered. What do we do with this? How do we organize this data? So these are the steps I'm going to take a little time on. we need to identify the key signs and symptoms, create a problem list, medicalize the problem list that you've created, and create a problem representation. So I'll go in step by step with each of this. So I've identified the key symptoms. They all have been highlighted in red. I've highlighted the key signs, and I have made a simple problem list. Okay. Now into this problem list, one must also remember to include must-have features if the conditions you're thinking of have them. For example, without jaundice, you cannot make a diagnosis of ascending cholangitis in a patient with a right upper right hypochondriac pain. Remember the rejecting factors. An example would be if there's hyperreflexia in a patient with CNS problems, it cannot be a GB syndrome. So it's a rejecting factor. Also add the important positive and negative history and physical findings. So I've done that. I've added the important negative findings. I've added an important physical finding which will support one of the diagnoses, that is symmetrical chest excursion is a feature of pneumonia. I've also added that there is absent JVP, absent pedal edema, no murmur. So the important negative features have been added. Okay. So after you've done making the problem list, you can now, you must medicalize. Medicalize is to, it's not progressing. Okay, medicalize is to apply medical terms to the layman's language or the way the patient described his signs and symptoms. So what is, I'll just give you examples using the same case. So patient with shortness of breath, it is dyspnea and cough. Fever with blood thin sputum, fever with hemoptysis. Pulse rate of 102 per minute, tachycardia. Respiratory rate of 25 per minute, tachypnea. And a grade 3/4, this is not necessarily in this case, in the right and upper limb, hemiparesis. Okay, so it's important to medicalize. After you can, along with applying medical terms, we also have to keep certain semantic qualifiers in mind. And what are they? One is the time course and trajectory of the disease. So onset and whether and how is the time course? Onset could be hyperacute if it's minutes or hours. It could be acute if it is over days, subacute if it is over weeks, and chronic if it is over months. So in our patient, the onset was of 2 days duration and it has been progressively worsening. So it is acute onset. Keeping the same, the symptom of hemoptysis in mind, if it was hyperacute, one would think of pulmonary embolism. If it was acute, it could be a patient with viral bronchitis or pneumonia. Subacute, if the patient has had hemoptysis over a period of time and had the symptoms over weeks, one would consider pulmonary cox. And if it was chronic, one would think of bronchiectasis. So this is how the time course, the onset and the trajectory would help us in sort of pinpointing the diagnosis. Then we also must take into account epidemiology and risk factors. So this would include age and gender, elderly male, past medical history of diabetes, more likely to develop community-acquired pneumonia. He's got risk factors. He's a known smoker for the past several years. So he could be still having COPD and there could be acute exacerbation. He could be having a cardiac event which has caused his dyspnea. What about pets and travel? If there's a recent history of travel to the nearby forest, then you could think of rickettsial diseases and other conditions. If we normally take history of pets in ophthalmology if patient has toxoplasmosis. So you need to keep this in mind when you make your problem list. So I have done that. I've highlighted the time course. I've looked at the risk factors, past medical history, and I've added it to my simple problem list. So after that, I've also applied medical terms. So it is acute in onset. There is dyspnea, cough, fever, hemoptysis. He's a smoker with diabetes, hypertension, who's got tachycardia now, tachypnea, hypoxia, and there is consolidation, maybe a consolidation of lungs based on our physical findings. So you may ask me, why do we need to do this? Why should we medicalize? Why should we create the problem list? So medicalize means is to apply, as I said earlier, to apply medical terms to layman's terms and language. It is important because that's how we learn and that's how we practice medicine. We do not, when we make a search, we do not go and look for breathlessness. What we search for is, we search for dyspnea, causes of dyspnea. When we are looking for causes of weakness on one side of the body, we are searching for hemiparesis or hemiplegia and not for weakness of limbs. And so it is important that we learn to apply these medical terms. Also, sometimes when you apply the correct medical terms, differentiating different conditions becomes important. The patient's words may not be adequate for you to pinpoint the exact condition. I'm going to give you an example. A 28-year-old female has come with multiple painful joints. If there's evidence of redness and swelling over the joints, it will become polyarthritis. So the same 28-year-old female who has come with history of multiple joint pain, but on movement, but on examination, there's no signs of inflammation, one would think of arthralgia. We all know that the differential diagnosis of polyarthritis is very much different from arthralgia. It completely takes away the course of your thinking when you're comparing polyarthritis to arthralgia. Similarly, a young female presents to you with acute loss of vision and is associated with right hemiparesis. It is important to apply these terms because then in such a situation, one would think of multiple sclerosis. In contrast to a young, similar 23-year-old female who comes to you with acute loss of vision with bladder incontinence, straight away one would start considering transverse myelitis, and potentially the diagnosis could be a neuromyelitis optica. And that is why it is important to medicalize. Why should we create a problem list? Problem lists help us to prioritize the developing differential diagnosis, or it may even help us to completely alter the diagnosis. And I'm going to use the same example of dyspnea and hemoptysis. So there's dyspnea and it's associated with tachycardia, then all that we thought of from the beginning, respiratory failure, CCF, COPD, pulmonary embolism is highly possible. But on the other hand, if the patient has dyspnea with bradycardia, then we may consider a heart block and ECG would become the first thing that we would do. If there's dyspnea, cough with cyanosis, then the differential diagnosis will turn upside down. Pulmonary embolism will come up in your differential diagnosis and the other respiratory problems may go down a little bit. What if the patient has dyspnea with normal auscultation? Pulmonary embolism is almost sure of this is the diagnosis. If the patient has dyspnea with syncope, then valvular heart disease should be considered. Similarly, in India, if there is a cough with dyspnea, one would think of cough with hemoptysis, one would first think of tuberculosis. But if there's cough with hemoptysis with hematuria, then we would never consider tuberculosis. Rather, we would think of good pastures and GPA. So that is why it is important to create a problem list and a problem list which has been medicalized, as I have done here. So is there any more left? Yes, we need to now create a problem representation. What is this problem representation? Problem representation is the process of distilling critical information from a broader clinical scenario. It should include who is the patient, that is the epidemiology. What is the syndrome of signs and symptoms? What is the time course and what is the risk factors? Using appropriate medical terms and applying semantic qualifiers to the case that we discussed so far, this is what a problem representation will look like. A 67-year-old male with acute onset dyspnea, cough, fever, and hemoptysis with evidence of tachycardia, tachypnea, hypoxia, and respiratory findings suggestive of lung consolidation. This is what the problem representation look like for our patient we are discussing. I'll just give you one other example. A 39-year-old woman comes to emergency not feeling all right. 1 minute fine, another minute chest is fluttering. My heart is jumping all over the place and beating very fast with a feeling of imbalance and near blackout. Similar episodes in the past 2 years. but now has been increasing in frequency. But however, the patient feels better on bending forward. So if you have to first medicalize, identify important terms here and medicalize, this is what it will look like. So I've identified important terms here, and I am going to medicalize it and write a problem representation. So the 39-year-old female has come with chronic, intermittent, increasing episodes of abrupt onset palpitations, pre-syncope, which improves on Valsalva. So 1 minute fine, another minute chest is fluttering, my heart is jumping all over and beating fast. So there's something sudden in onset and there is palpitations. There's imbalance and near blackout, pre-syncope. So there's been episodes in the past, so it becomes chronic but episodic and with increasing frequency. And feel better on bending forward is Valsalva. So there is relief of symptoms on bending forward. And so that is why this problem representation. So after that, what do? We, based on our problem that we have outlined, we generate differential diagnosis. How do we go about doing that? So we can either, as Dr. John showed the illness script, we create now a patient's illness, patient script based on the patient's findings. So we've got these 4 important diagnoses in our mind. It could be 3, it could be 4, not more than that. Community acquired pneumonia. What are the features which favor it? And what are the features which go against it? What goes against it? Almost all features are fitting into community acquired pneumonia, except the almost hyperacute onset. Can it be congestive heart failure? It could be. However, fever goes against it. And there's absence of pedal edema. There is no elevated JVP. There is no palpable liver. And the patient has bronchial breath sounds. Could it be pulmonary embolism? Again, fever is a point against it. There is normally the respiratory examination, auscultatory findings are normal. But here we have a bronchial breath sound which goes against the diagnosis. So based on that, we have now changed the order of our diagnosis to community acquired pneumonia as the most probable diagnosis, but we still have the others at the back of our mind. So this is how we generate differential diagnosis. Comparing the patient's script to the illness script, similar to what Dr. John had showed in the previous presentation, finding what are the factors which favor this diagnosis, also keeping in mind factors which rule out other conditions, and then come up with the most probable diagnosis. So you could also do the same thing using the Venn diagram. I'm not going to go into details of the same. Over to you, Nachi.
Thank you, Dr. Suneetha, for clearly delineating the steps that are involved in clinical reasoning with a beautiful example that all of us could relate to. And just to summarize, we look at creating a problem list. And after creating the problem list, we then proceed to medicalize and use semantic qualifiers to create a problem statement from which we create a differential diagnosis. So thank you, ma'am. So of course, now the obvious question for all of us is that from the first speaker's responses, we realize that clinical reasoning is really important. And we know now the steps in clinical reasoning. So probably the obvious question, and this question is for Dr. Sanjiv Lewin, is how do we teach this important skill to our MBBS students? So, sir, I'm going to make you the presenter shortly, and you should be able. Okay, thank you, ma'am. And you should be able to share your slides.
Good afternoon, everybody. At the onset, I sincerely like to acknowledge the presence of 2 people in this audience, Professor Vishnu Bhatt, who was part of the NTTC team in JIPMA, who sowed the seed of interest of medical education in me 27 years ago. And of course, Professor Katur, who actually fertilized the seed as the plant was growing as part of the JNMC medical education cell. I'm going to focus on how and when to teach clinical reasoning. What we do know, and we've already realized, is that it's all about data collection, history, examination, and test. And this data collection begins the process of critical reasoning. From the data collection, we tend to go to organization of data, that is problem listing, medicalization, problem representation, and then we generate hypothesis of what we think is a potential most likely differential diagnosis with a few more differentials which are less likely, using illness scripts patterns and compare and contrast. And you can see at every level, history, examination and investigations, we do this process and it goes around in a circle. Therefore, to teach clinical reasoning, I would have to teach data collection, how to organize the data, and how to generate hypotheses. The data collection is what we usually do quite well when it comes to history taking and examinations. As teachers, we tend to demonstrate by role modeling history taking, observed by students, and repeatedly practiced by students who are monitored with corrective constructive feedback of how to collect data. We do it by making students elicit histories, perform physical examinations repeatedly, and may to an extent also ask them to discuss what was the appropriate test they'd like to have. This would, of course, be wherever there are patients, outpatient, inpatient, or even during case discussions with paper cases. We then need to teach them about organizing, creating this data, collecting this data, and then organizing it into problem listing after medicalization, and then summarizing the entire history, the history and examination, and maybe when we get the labs, include the labs in the summarization as one statement, preferably. So to do that, again, the clinician will have to repeatedly demonstrate by role models, preferably in the presence of a patient where students are observing, and ask the students to practice this medicalization and summarization of the history, summarization of the examination, and summarization of the entire picture in a supervised manner with constructive feedback to learn how to organize data which is collected. So therefore, you may end up identifying key points and summarizing history, insisting on decisions on purposeful physical examinations in the context of the history, and deciding on appropriate tests, and also repeatedly asking the student to summarize at each stage. Again, wherever there's a patient or a patient condition being discussed, inpatient, outpatient, or in any sort of case discussion, it's a good idea to use this possibility of role modeling thinking and supervising and presenting feedback on methods of organization of data. Which leads us to the third component, which is generating a hypothesis. And this is necessary predominantly to decide on what is the order of our differential diagnosis, and banking entirely on a list of illness scripts which we have learned in theory or in clinics, and recognizing certain patterns and being ready to compare and contrast to justify why the diagnosis is meningitis and not migraine, or the diagnosis is community acquired pneumonia and not heart failure. That requires issues. And therefore, for us to teach that, again, there is nothing better than demonstrating this hypothesis, giving reasons by illustrating scripts, by showing pattern recognitions, or giving points for and against the differential diagnosis, and asking students when they present data and organize it and summarize it under supervision to then recommend and give feedback of what reasons you would differ or you would agree with the differential diagnosis and the generating hypothesis. And at each point of the interaction, this is vital. You may ask the student, why did you decide that community acquired pneumonia is the first possible diagnosis? Why is it that you don't consider heart failure as a possible diagnosis? No, explain to me why migraine is not the first diagnosis, but it is meningitis, depending on the case scenario. Justification repeatedly, asking them to think about their scripts which they had, the patterns, and ability to give points for and against by comparing and contrasting. Again, nothing stronger than in the presence of a patient in the outpatient, in the inpatient ward around a patient, or during case discussions on paper cases. So it is clear when we are trying to teach clinical reasoning that the patient is the center of teaching learning. If it is in the pre and paraclinical subjects, it's very important to understand that the pre and paraclinical is the fundamental reason why some of us have very strong illness scripts. We understand the pathophysiology, the anatomy of the brain. We understand the nerve supply and the pain pathways to understand why headaches have potential differential diagnosis. In the case of the pneumonia versus heart failure, we understand the pathophysiology of heart failure, why the liver enlargement, the JVP, the pedal edema becomes a pointer towards heart failure as against a simple pneumonia. And therefore, in pre and paraclinical, do not even think that this is not important, but all our fundamental strengths of building good illness strips, recognizing patterns are very important, starting with pre and paraclinical, especially if pre and paraclinical give clinical examples and show relevance of why they are teaching particular things. Of course, for the clinician, nothing more than outpatient with multiple patients being seen, inpatient ward bedsides, case discussions, tutorials which hover around a case, and in the case of postgraduates, clinical pathological conferences. The idea is the teacher needs to think aloud of why he or she is thinking of differentials, deciding on particular examinations, and deciding on particular investigations to demonstrate the thinking process, which is basically clinical reasoning. Giving opportunities to discuss, to share thoughts, and to justify further strengthens clinical reasoning. So it appears that role modeling is very important to teach clinical thinking, practice, and repeatedly get students to practice under supervision with constructive feedback on the thinking aloud they give at the level of history, and the examination, at the level of history, examination, and also the investigation reports. At each of these three stages, it makes a lot of difference. As I mentioned earlier, pre and paraclinical subjects, very important for me to develop strong library of illness scripts in my brain, patterns to be recognized, and to be able to justify points for and against. Elderly person, cancer; young person, less likely to be cancer, for example. Outpatient clinics, simple methods to teach clinical reasoning is the 1 minute perceptor and the snaps, of course. In inpatient wards, bedside clinics, case-based tutorials, and never forget that even a lecture or a tutorial, which is predominantly theory, if it has a case study to initiate and induce the discussion, it's a very strong tool to strengthen clinical reasoning. I will not be going through the 1 minute perceptorship, but will refer you to the General Internal Medicine 2001 article by Fernie, where there is a need for student in that 1 minute to make a commitment in the outpatient classically and give reasons why, clarify a fact, and maybe a teacher teaches a general single point to summarize, especially when it's a very busy outpatient, because this alone strengthens clinical reasoning. Snaps, little more elaborate, where you need to summarize, narrow a differential diagnosis, analyze the history, probe for more questions, for more information, plan management, and maybe walk away selecting information for self-directed learning. Again, I'm referring you to the Academic Medicine 2003 article by Wulpan on snaps. With this, I think it's important to recall to teach clinical reasoning and to learn clinical reasoning. It is all about the patient and the clinician-student encounter, because the patient remains at the center, and without the patient at the center, one cannot really understand or teach clinical reasoning. And this is periodically required on and on and on, and a vital element to be rational in diagnosis. Thank you so much.
Thank you so much, sir. And I think it is very encouraging for all of us in that the methods that you mentioned are familiar to most of us, and it is possible to develop clinical reasoning with the existing methods if we put some thought into it and we understand the clinical reasoning process. And I think it's also a good opportunity to learn two new methods that you mentioned, the OMP and SNAPS. So certainly those are two additional methods that we can incorporate into our teaching. Thank you so much, sir. And we've come to the end of this panel discussion, and we do have 5 or 10 minutes for a few questions. And the first question I'd like to address to Dr. John. And this is the question that was asked by one of the participants. I'm going to read it out, sir. Reasoning is affected by adverse outcomes in our previous experiences. So how do we teach residents to overcome them, especially over-testing and over-treating?
Yeah, thank you, Nachi. I guess we were having a challenge with this session because there's so much to talk about clinical reasoning. And so we are trying to see how we can make it concise. I think this is a fantastic question because that's the heart of what clinical reasoning is all about, on how you make the decisions. If you allow me to share a slide or two, maybe I can answer this very briefly, 2 slides.
Sure, sir. Just give me a minute
to share.
Yeah, just give me a minute, please, sir. I just...
Sure. Because I sort of pulled out 2 slides.
Yes, sir. Yes, sir. I think you should be able to share now, sir.
Now I'll share now, yeah.
Yeah.
Now, can you see my slide now?
We can see your slide, sir.
Okay. So, basically, I hope this answers the question. When you come across a situation where, like, when we have not come to the end of the decision, we are in that uncertain phase, uncertain diagnosis. Basically, if you have enough evidence, either from history or from investigations, if you get evidence in support of a diagnosis, you go towards treatment. If you get evidence against the diagnosis, you go towards thrashing the diagnosis. You take it off the table. So basically, this is based on these 3 factors: cost of treatment, cost of testing, cost of doing nothing. I'll give you a few examples here. Now, the treatment threshold, where we put the treatment threshold is based on these 2 factors, cost of testing versus cost of treatment. Now, if you take myocardial infarction, getting an ECG done is not very expensive, right? So you would like to do an investigation here. So you will shift this threshold upwards, right? So in myocardial infarction, you would not hesitate to do an ECG or even an enzyme test there. So you will do the test and then treat. On the other hand, let's take, for example, gastritis. Gastritis, maybe you need to do an endoscopic examination. You may want to, the cost of treatment is low, and so you can give some antacids and check it out before you go to doing the endoscopy. So this decides whether you want to do the test. For example, if it's gastritis, you'd rather treat first and then, so which means you shift the threshold down, so you treat it. If it's myocardial infarction, you shift the threshold up, so that, because it's important to clarify and then treat. Now let's take another example on this side. Cost of testing versus cost of doing nothing. Pulmonary embolism. Dangerous to do nothing, safe and cheap testing. So you will push this particular threshold downwards so that you will test for embolism. You won't sort of leave it to chance there. On the other hand, so this is how you sort of make that decision. Now, that's one way to look at it. And of course, sensitivity versus specificity on what test that you will choose, whether it is going to give you value for that, shifting the probability from low to high. And let's say I'll give you two examples here. This test A is more specific than test B. So in which case, if it is more specific, it will help you make the diagnosis. It will push the person upwards towards higher probability. But if you choose to sort of exclude a case, you'll have to use a more sensitive test. So I'm just giving you two examples here. And basically to say that this is what reasoning is all about. And we just said clinical reasoning, but the entire part of reasoning is based on probability. It's based on pre-test and post-test probability. It's based on what is the chance that this person may have this particular problem. It's based on studies, it's based on statistics. So that's what reasoning is all about. And the question that was asked is, how do you make sure that a postgraduate student who learned this and prevent him from making the mistakes? So in order to do that, we have to actively discuss this. We have to talk about specificity. We have to talk about cost of treatment. We have to talk about which test is a CT better than an MRI. All that is part of reasoning. It's not just with diagnosis. It's also to do with when do you do the test, when do you trash the diagnosis, when do you don't trash the diagnosis. So that's at the heart of clinical reasoning. And I think the question was that fear that the question sort of implied is the reason why we need to teach clinical reasoning. I hope I've answered that question.
Yes, sir. So thank you, sir. The next question is for Dr. Suneetha. Actually, this was the question that I wanted to ask her, but a participant sort of has asked a similar question. As clinical examination teaching has been challenged in this COVID era, how best to overcome it without compromising safety in teaching and evaluating, but simultaneously imparting psychomotor skill? So my related question to you, ma'am, was that is it possible to teach clinical reasoning online?
Thank you, Nachi. Can you hear me?
Yes, ma'am.
Yeah. So we did. Is it echoing too much?
There is a little bit of echo, yes, ma'am.
Is it better now?
It's slightly better, yes, ma'am.
Okay. So basically, we did during the COVID times, we conducted a clinical reasoning workshop for our family students. So we used case examples and we taught them the steps of clinical reasoning.
Sorry to interrupt, ma'am. There's an echo, ma'am. So, ma'am, what we can do is maybe we can address the third question to Dr. Sanjiv first. You, ma'am.
Just put it off.
So this question is for you, Sanjiv sir. The problem with consultants when asked to follow stepwise approach, like what we see in OSCEs, is that their brains are short-circuited and can jump many steps, but they still arrive at a correct diagnosis. So what can teachers do to overcome this super guru status? So basically the teachers, they jump steps because they are so experienced and they are not able to relate to the students. So they don't break it down like you suggested, sir, in your teaching methodology. So how do we overcome this tendency for teachers to miss steps when they teach students clinical reasoning?
If we want to teach clinical reasoning, we have to think aloud. We need to explain to the student the points for, the points against, the epidemiology, the pathophysiology, the common symptoms, the common signs, the investigations we expect to be positive, which gives weightage to a particular differential diagnosis. If you truly want to teach clinical reasoning, you need to demonstrate by role-playing your thought process, and only then the student has an opportunity to learn the process. So unfortunately, if you go from A to Z and clearly say that's definitely the diagnosis and do not explain it to the students around you who are watching and observing your differential diagnosis, or you are highly dependent on a blanket of investigations which no Indian can afford, you will end up with a diagnosis probably by chance, but you have not taught or demonstrated clinical thinking or reasoning. So that's the only suggestion I have is teachers need to illustrate and think aloud so that students understand why we take certain decisions. Unless we don't want them to know how we are thinking or don't want them to know how we don't think. Over.
Okay, sir. Thank you very much, sir. So we come back to Dr. Suneetha. And the question to her were two related questions. One is it possible to teach clinical reasoning online? And similarly, one of the participants asked, in the COVID era, it's been challenging. How can we teach students without compromising safety? And she also asked a question about psychomotor skills.
Thank you, Nachi, and sorry about the problem with the computer.
Yes.
So we did conduct a clinical reasoning workshop online. It went on for about 5 weeks. They had a lot of work to do. We first taught them the steps of clinical reasoning, gave them paper cases, and then they were all discussed, once a week over a period of 5 to 6 weeks. It was appreciated by the students. And for coming to this, how to teach them psychomotor skills. So what we plan to do in St.John, in the different departments, I can speak for my department. Every faculty is going to get 5 students posted with them. And we are now working in literally 2 shifts, starting early in the morning at 8. And we get 2 batches of students in the morning OPT itself for 3 hours and 3 hours. And so the basic intent is that they're taught, every student is taught clinical skills by spending time with the faculty wherever they are. So whatever opportunity, clinical opportunity you get, you could teach them the psychomotor skills.
Thank you, ma'am, for answering that question. And I think Dr. Sanjiv also has mentioned some points. So post students to faculty, not units. Hence, you strengthen the student-faculty ratio. Sitting in models, parallel consultations, asking students to work up a patient and return, reporting back with a summary. Pool all faculty and residents as teachers. So lots of ideas for us to implement in the COVID era and CBME era. So I think we come to the end of the panel discussion. And on behalf of all the panelists and myself, it's been a pleasure and privilege to participate in this panel discussion, and we sincerely thank the organizers for inviting us. It was a really enjoyable experience for all of us. Thank you so much.
Thank you, Dr. Nachiket, for coordinating that session very well. It just went like a clockwork. And before we wind up, I'd like to ask Dr. Kotur if he has any last words to say. I have a message from Dr. Bhatt in the chat box for you. He said very nicely organized and conducted session. And he said he especially appreciates the coordination between the panelists and all the resource persons. Over to you, Dr. Kotur. Do you have any?
Yeah, before I say thanks to the team from St. John's, one or two some fundamental questions like clinical judgment are I think so Sanjiv can answer that.
Sir got a little bit in between. Sir is asking whether clinical judgment and clinical reasoning are one and the same. You got disconnected for a minute in between, sir.
So you are the judge of it. You can be the judge of it. I don't know whether there's a difference between clinical reasoning and clinical judgment. It sounds very similar. I think the judge is deciding whether it is community-acquired pneumonia or is it heart failure? Except we don't want this judge to be authoritative. There are no rules and laws which he has to follow. As you are well aware, it is an art and science. So we need to have a little more reasoning rather and little less judgments. Others will end up in a consumer protection judge court. Over, sir.
Can I?
And can we say that clinical reasoning is one of the competencies?
Certainly, sir.
Can
I
it
have
be
a.
categorized as a...
I think you asked whether clinical reasoning should be a competency. It's such a broad, it is part of clinical competence. So certainly, whether it can be a very broad competency, but it'll further be broken up into multiple areas. And I said it's possible that information gathering is a competency, information organization is a competency, rather than just clinical reasoning, because it's so huge. I think we can easily make more sub-competencies under that. But I don't know, sir. You sound right.
Say that it is group of competencies.
Yes, that sounds better, yes. Many competencies are needed to have the... Thank you, the team. Dr. Bhatt wants something? What, Malaki?
Nothing much, sir. I think most of the doubts have been clear, and I think it's a good presentation.
Yeah.
And I think they've gone into step by step in a well coordinated way, and I think I appreciate their presentation.
Yeah.
Yes. Thank you very much.
Yeah.
Thank you, sir.
Thank you, sir. Actually, like if I were to say, summarize, I was just reading about this book by Oliver Sacks. He's a famous neurologist who has written the book on awakenings and the man who wore his wife's hat and all that. So there is one very nice book on anthropologist in Mars. It talks about somebody who has got an autism and how they try to fit into the real world. And this person relates the experiences. He says that every single experience what I have is like a video cassette. And I keep adding cassettes to my library. And every time I come across a new finding, I go back and look into my library and see what matches with it. And the more I do it, the more faster I'm able to do. I think that's a very fascinating brain work which goes behind this clinical reasoning process. So I think on that note, we will conclude today's session. On behalf of the Scientific Society of Aarupadai Veedu Medical College, the Constituent College of Vinayaka Mission Research University, I would like to thank the entire team from St. John's, Dr. Sanjiv, who actually put up with all my demands to reschedule this session because of this session got rescheduled because of the Diwali holidays which came in between. I would like to thank him. I'd like to thank Dr. Nachiket, who did a very good session trying to put all these things together, Dr. Suneetha, and also to Dr. John. It was very nice having you all here, even though it was virtual. Thank you. And before I close, I would like to say a few things to the audience, that we would say that we'll be sending the link for downloading the e-certificates to you tomorrow. So please download your e-certificates. You could go to our site also and get. We'll also be posting the YouTube recording of this particular session so that you can actually watch it at your own leisure and see. You can pick up many more things as you watch it, or reruns of it. So that is it. And also, we'll be back next week. We are finishing our series 6, that is exploring concepts in medical education, with this episode. So we'll be starting series 7, and series 7 we are looking at concepts in cancer therapy. So the first session will the additional professor and HOD of radiation oncology at JIPMER. He will be talking about the recent technological advances in the treatment of radiotherapy for cancer. So that is the session in store for you next week, guys. So please stay tuned to all the announcements which keep coming. And we would request you to join us again next week at 2:45 p.m. so that for another interesting session. Thank you very much. Stay safe and stay productive and healthy. Thank you very much. Bye-bye, friends. I sign off on behalf of the Scientific Forum, and we'll close this meeting with this. Thank you. Bye.
Bye. Thank you, ma'am.
Thank you,
sir.
ma'am. Thank you. Thank you.
Thank you.
Bye.